Welcome. I'm Dr. Pinner, and welcome to my humble abode. It's nice to see some fans of pathophysiology. I guess you're wondering why I asked you here today. Well, one of the things I wanted to discuss was this recent article that I provided entitled Mechanisms of Acute Coronary Syndromes. It was published in the New England Journal of Medicine in May 2013. Now, this article starts off by describing acute coronary syndromes. You know from our discussion in class that acute coronary syndromes consist of either unstable angina, that'd be number one, number two, acute subendocardial or non-transmural infarctions, and number three, transmural infarctions, which are also called STEMIs, which stands for ST segment elevation myocardial infarctions. Now, at the start of the article, it states atherosclerotic lesions in humans typically form over the course of years to decades. Okay? And despite the chronicity of atherosclerosis, the fact that they progress very, very slowly, thrombotic complications, what he's referring to as acute coronary syndromes, occur suddenly and oftentimes without warning. Yeah, you would expect if there's a slowly progressive disease where plaques are slowly growing over the course of years to decades, that somebody would experience slowly progressive anginal symptoms, ultimately culminating in a myocardial infarction. But, paradoxically, that's not what often happens. Many times, a patient who presents with an acute coronary syndrome will have a fairly stable clinical picture. For instance, they may have symptoms of stable angina pectoris that recur at maybe 3 to 4 blocks of ambulation, and then suddenly one day they suffer a massive myocardial infarction. We hate when that happens, but it's not that uncommon. I'll give you an example. Back in the 1990s, a nurse referred her husband for a complete evaluation. The husband was in his late 40s, and she was concerned because, number one, he was a smoker, and number two, he had a very strong family history of coronary artery disease. In fact, his dad had died of a massive MI in his mid-40s. Now, when he presented to my office, we did a complete physical exam, which was normal, fairly unremarkable. We then proceeded to perform both an echocardiogram, which is a cardiac ultrasound, and a stress test. Now, the echocardiogram demonstrated normal chamber dimensions, no evidence of left ventricular hypertrophy. There was normal valve function and normal wall motion. In other words, the heart looked just fine. Subsequently, he underwent a stress test in which he exercised for 10 minutes into what's called a Bruce protocol. The Bruce protocol is a standard protocol used in treadmill testing, which prescribes both the rate of the treadmill as well as the angle of incline at each stage of the exercise protocol. And using this protocol, your goal is to increase the patient's heart rate to 80% or more of their estimated maximum. Now, if this gentleman, let's say, was 50 years old, how do we know what his maximal heart rate is? Well, we can estimate it by using the formula 220 minus age, in this case 220 minus 50. That would give us an estimated maximum of 170 beats a minute. When we perform treadmill testing, our goal is to achieve at least 80%, somewhere between 80 and 100% of that maximal target heart rate. And in this gentleman's case, we were able to reach target heart rate without any evidence of EKG abnormalities or ST segment shifts. Okay, so with this information, I was able to tell the patient and his wife that at this point in time, his heart looked pretty good, and in a sense provide some reassurance. Now, here's the crazy thing. About 2 weeks later, this same patient showed up at the St. Charles General Emergency Room at 3 o'clock in the morning with an acute myocardial infarction. Wow. Okay. So, I got a call at about 3 a.m. advising me of this gentleman's presentation in association with ST segment elevation across the anterior precordial leads on his EKG. Now, St. Charles General is a small hospital. It did not have a cath lab. So I provided orders to begin an infusion of TPA, tissue plasminogen activator. TPA is a thrombolytic agent. A thrombolytic agent is a medication that dissolves clots. And sure enough, after about 30 to 45 minutes of the TPA infusion, the patient's chest discomfort suddenly abated. And with that, the ST segment elevation on his EKG began to fall. Okay? This is indirect evidence of improvement in the clot, dissolution of the clot, and reestablishment of blood flow down the coronary artery. Okay? Now, following completion of the thrombolytic therapy, we began the patient on a heparin infusion. Heparin's a blood thinner, the purpose of which was to prevent the clot from regenerating. Okay? And on this therapy, the patient in fact stabilized and did quite well. So that 2 days later, we transferred him to a nearby hospital with a cath lab to perform coronary angiography. Now, when we did the angiogram, the culprit lesion, in other words, the lesion that was responsible for his infarction, demonstrated an atherosclerotic plaque that narrowed the lumen of the coronary artery by about 40 to 50%. In other words, it was not a high-grade stenosis. There was a small amount of residual thrombus, but now the vessel was wide open. Let's go back. In terms of this patient's MI, serial cardiac isoenzymes performed after admission revealed a relatively small amount of damage. In other words, his heart attack was aborted, and he would have suffered a much greater degree of tissue necrosis had not we reestablished blood flow through the coronary artery, through the LAD. So, this particular clinical scenario underscores the paradox that's discussed on the first page of this particular article, that oftentimes patients have relatively stable symptoms which are suddenly interrupted by sudden vascular occlusion and a myocardial infarction. Okay? And that serial angiographic studies, this is further down in that article, oftentimes reveal that when you do an angiogram, the underlying lesion that was responsible for the infarct is not flow limiting. Okay? And in fact, it's the rupture of the plaque that's responsible for the infarction. Now, on page 2, at the bottom, it asks, if the progression of luminal stenosis to a critical narrowing does not cause many acute coronary syndromes, what mechanism produces these dramatic and sudden manifestations of chronic atherosclerosis? Okay? It goes on to describe the two most common mechanisms that are responsible for acute thrombosis and acute coronary syndromes. The majority of deaths that occur in the setting of an acute coronary syndrome are caused by frank rupture of the plaque's fibrous cap. Remember in class when we talked about atherosclerotic plaques, we talked about a lipid core which is surrounded by a fibrous cap. That fibrous cap is produced by smooth muscle cells which generate collagen and other connective tissue elements. And this cap separates the lipid core from the bloodstream. Okay? So the vast majority of plaque ruptures and thrombus formation are due to an unstable fibrous cap. Okay? Now, a secondary cause of these acute coronary syndromes is erosion of the endothelium, of the coronary endothelium overlying the plaque. Okay? It goes on to say, a fibrous cap typically overlies the lipid-rich center, also known as necrotic core, of an atheromatous plaque. It says this fibrous cap stands between the blood compartment with its latent coagulation factors, in other words, coagulation factors which aren't active, and the lipid core, a portion of the plaque filled with thrombogenic material. If that plaque ruptures and the bloodstream is exposed to that atherogenic material, that thrombogenic material, then that's going to trigger activation of the coagulation cascade. It's going to lead to formation of a thrombus at the site of the plaque. Now, it goes on to say that more than 30% of plaques that cause fatal rupture are associated with luminal stenosis of less than 75%. Again, over 30% of the plaques which rupture and cause death are associated with underlying plaques that are not high grade, that are less than 75% in severity. So, the idea behind this article is that acute coronary syndrome is due to some sudden change in atherosclerotic plaques. And that oftentimes, up until this change in the plaque, either rupture or erosion of the endothelium overlying the plaque, up until this acute change, the patient has a relatively stable clinical picture. Okay? Then it goes on the ensuing pages to describe the changes that occur within the plaque that predispose toward rupture. In other words, what happens within that plaque that triggers rupture? Okay?